I'm going to discuss the use of esophageal pressure and transpulmonary pressure, maybe asking this question: is this monitoring only for researchers? And probably a little bit by contrast with what we've seen previously, this technique I think is useful clinically, but needs very thoughtful clinicians. It's not an automated system. You need to think about your patient and you need to think about physiology. So there are a number of papers describing this technique. We have a working group called the Plug, which published at least 2 position papers. I recommend for those who are interested to introduce this technique to read these papers. And I'm going to describe 3 applications, and I will do it quite shortly. And because it's a bit complicated, I hope you won't be lost. 3 applications in the clinical setting. So why do we measure esophageal pressure? Because we want a surrogate of pleural pressure. And the pleural pressure is the pressure surrounding the lungs. And in this era of protective lung ventilation, this is the only way to precisely know what is the real distending pressure of the lung. Okay, if you measure the pressure at the airway opening, you just have the total pressure, which is moving the lung plus the chest wall. If you just want to know the pressure, which is simply distending the lung and subtracting the pressure moving out the chest wall, you need to measure this pleural pressure. And the simplest way to do it is to put a catheter in the esophagus. Not a very complicated technique in the ICU. I think most of you are used to place feeding tubes. Not very different. There are, however, a number of steps you need to do to be sure your technique is valid. So I'm not going to go into the technique. I'm going to discuss first the absolute value, because there has been a lot of controversy, and this absolute value needs careful measurements like calibration, being sure you're well placed. We do that routinely in my ICU, but before you do that, you again need to think about it. So this is where your esophageal catheter will be placed approximately in the esophagus, and the esophagus is submitted to the pleural pressure. It's the same pressure than in the pleural space. But there is not one pleural pressure. And this is very important to understand why there has been this controversy about the absolute value, what it represents. And if you wish, for instance, the pleural pressure is different in a supine patient in this position, in the non-dependent part, where it's relatively low, compared to the dependent part, where it's much higher. There is what we call a gradient between the non-dependent and the dependent part. And this is why when you have a pneumothorax in a patient like that, it's only in the non-dependent part usually. And especially in ARDS, where the dependent pleural pressure is very high, you never will see a complete collapse of the lung. So the esophageal pressure is measuring the pressure in the pleural space approximately at mid-chest or between mid-chest and the dependent part. So this is what you measure. You don't measure the pressure, the lowest pressure in the non-dependent. You don't exactly measure the dependent one. You're closer probably to the dependent one. So I'm not going to go into details, but we really validated that in different settings. We went to animal studies, large animals like pigs. We went into human cadavers to be sure we have the correct shape of the thorax that we will observe in patients. And this is the value of the gradient between the top or the non-dependent and the dependent. It's around 10 to 12 centimeters of water. So you imagine that people who have compared the one value in the pleural space to the esophageal pressure, depending on where you measure in the pleural space, well, you may have the same or you may have a difference. So this is the data in pigs. In pigs, the esophagus is very posterior, so the esophageal pressure is very close to the dependent value. In human cadavers, it's again depending exactly where you place the catheter, but it's more in the middle. So let's say in humans, and we have now data in patients after thoracic surgery confirming that, the esophageal pressure measures the pressure somewhere between the dependent part and the middle. So this is important because when you say, okay, I'm going to use this absolute value to, for instance, titrate my PEEP, and this is the first indication, you have to realize that you do that based on the pressure at this location. So the group of Boston, Danny Talmor and Steve Loring say it makes sense to try to keep the lung open by having a positive transpulmonary pressure. Transpulmonary pressure is simply the difference between airway pressure and esophageal pressure. And this is a nice example where you see, I don't know if you see, yeah, you see the esophageal pressure here, which is high, right? It's maybe 14 centimeters of water. So they say, if we want to keep the lung open at that level, we need to put the PEEP a bit higher. So they put 16 centimeters of water. And indeed, the difference between the two, the transpulmonary pressure, is indeed positive. And in the first study, using this technique and comparing to a low PEEP FiO2 table, they found that respiratory system compliance improved, the oxygenation improved, and there was some signal suggesting that maybe there could be benefit in mortality. They did a second trial, which was unfortunately negative in terms of global outcome. The trial was different. It was a little bit larger, but still it's approximately 100 patients in each group. But it was compared to the high PEEP FiO2 table, which is different from the first one. And they didn't see a difference in outcome, and so, of course, some people were disappointed to say maybe that's not the ideal way. And that may not be the ideal way. So why did we think this study was not positive? First, I doubt that a study of 200 patients will show difference in mortality. Second, I think the limitation here is that it's only one aspect of the mechanics, which to me makes sense. But it makes sense only if the lung is recruitable. If the lung is recruitable, that makes a lot of sense. If the lung is not recruitable, I think you should keep the lung closed and let the lung heal. And I'm showing this classical slide where you have examples of CT scan taken at 5 and 45 centimeters of water, and you have here an example of patient who is not recruited by 45 centimeters of water. You see the effect of pressure is only to distend the aerated lung and to squeeze the heart. And this is an example of a patient who is recruiter. The lung is clearly reopened at 45, and interestingly, you don't see much effect on the heart. So if we don't take into account the fact that some patients are recruitable, some are not, I think this is one explanation of the mistake. So do we think we cannot use this value? I think we do. I think it's a very pertinent, relevant information, and I'm going to show you one situation where I think it's extremely useful. It's obesity. Because I think the hypoxemia we see in obese patients with ARDS, it's to a large part due to the load imposed by the tissue. I'm not saying the chest wall exactly, I'm saying the load. And look at this data. We collected a relatively large series of patients with ARDS with all ranges of BMI. from normal BMIs to obesity, which is BMI between 30 and 40, and what is called morbidly obese patients or severe obesity above 40. There was a very strong correlation between the BMI and this absolute value of esophageal pressure, which I showed you. So the higher the BMI, the higher the pressure in the chest. And this is why in these patients, I'm just showing one paper, there have been a number, you're surprised. Look at this part of the slide. This is morbidly obese patients, and this is different way to go to high PEEP, let's say. This is ZIP, and then this is positive transpulmonary pressure, different methods. You see no hemodynamic effect. Why you see no hemodynamic effect? Because the pressure you give is simply counteracting the load on the chest wall. So in my clinical practice, in obese patients, and we have more and more of these patients, I think esophageal pressure is a very important measurement to help to titrate the PEEP, not for recruiting the lung, maybe it will recruit the lung, but for counteracting this effect of the chest wall. You will be surprised how well tolerated in these patients are very high PEEP. Let's go to the second indication of the esophageal pressure or transpulmonary pressure. It's the effect of the chest wall by itself. I mentioned initially on the graphic that you want to separate how much of the pressure is moving the lung or distending the lung, how much is moving the chest wall. So if you look at this tracing, this is what you can observe if you put an esophageal pressure during controlled mechanical ventilation. You have the flow, you have the airway pressure, and you have the esophageal pressure, and this is the same scale, right? So if you look at the amplitude of the airway pressure, the peak is 40, the plateau is 30, and this is the amplitude of the esophageal pressure swing. You don't see really a plateau. The esophageal pressure swing is always much lower than the airway pressure because it's only due to the chest wall. So the airway pressure is measuring the total pressure. The esophageal pressure change is measuring the change due to the chest wall. Okay, so if you are interested to know what's the real pressure distending the lung, it's airway minus chest wall. And this is what is measured here with the transpulmonary pressure, where you can directly estimate the transpulmonary pressure change. I took these other papers from the plug group where you have an example of another kind of patient. This one is on pressure controlled. And you see in this patient, the esophageal pressure swings are much smaller, which would tell you, well, in this patient, most of the airway pressure is directly distending the lung, okay? Compared to the other one where maybe 25% were simply moving the chest wall. So this may be important in clinical practice, and there are some examples. And one way to express that, if you wish, is to use elastance. Elastance is the delta pressure. So this is a series of patients where, the chest wall is a very small part of the total respiratory system elastance. So most of the pressure is distending the lung. And this is a series of patients where, with a lot of abdominal complications, where a large part of the respiratory system elastance is due to the chest wall. So in these patients, you're not distending the lung by using 80 or 90% of the pressure, but only maybe 50%. And interestingly, if you take this ratio, how much of the elastance is due to the lung, how much is due to the respiratory system, and you take the plateau pressure, so the plateau pressure, the airway pressure, so you say my plateau is 30 centimeters of water, my ratio is 80%, so you multiply the plateau by this elastance ratio, if I'm correct, 30 times 0.8 is like, 23 centimeters of water, you would say this is an estimate of the lung plateau pressure. And in fact, we validated this value, but it's an estimate of the lung plateau pressure in the non-dependent area. Wow, that's very interesting. Because the non-dependent part of the lung is the lung which is submitted to the highest distension. So we have here an indicator saying we can measure the lung plateau pressure in the most at-risk location in the chest. So very exciting, and this is true in pigs, this is true in human cadavers, and some people have already used this value, saying when it's higher than 25 centimeters of water, and my patient is still sick, I go to ECMO. When my calculated value is much lower, I don't need to go to ECMO, I can increase the PEEP. And this is a very nice study because the two groups had the same airway plateau pressure. The last indication, and I could spend a lot of time on that, but we are a bit short, so I will describe it very briefly, is to use it during the most frequent situation in the ICU. It's when the patient is breathing spontaneously but assisted by the ventilator. And why it's important? Because this is the part of the pressure you don't see on the ventilator, which is also distending the lung. To make it in a simple way, this is a patient on pressure support. We are delivering like 15 of pressure support, so you would say 15 is really not that high. But this is the esophageal pressure swing the patient is doing. He's doing minus 15. So the total pressure distending the lung is 15 plus the other 15, or minus 15 if you wish. So this patient ventilated with 15 of pressure is not protected. He's distending the lung because his drive, his respiratory drive is stimulated by factors in the lung, not only the gas exchange, and this patient may be at risk of developing what we call self-inflicted lung injury. If you don't know that, you may simply switch the patient to pressure support and see the next day that the patient has worsened or has developed a pneumothorax, as described now in several case reports in the literature. So I think it's a very important information. You need a monitoring tool to see that. You need either a dedicated monitoring or a ventilator. And the last thing I'd like to mention here is that it may also make you rethink of the vascular pressures. Because the vascular pressure in the chest, which matters for pulmonary edema, are the transmural pressure, right? And this is an illustration of what it would mean for capillary pressure of in a normal range. When you have a positive pressure, well, your transmural pressure in the first case is very small. But if your capillary pressure, even being low, you add the negative pleural pressure, so when I say you add, it means minus, this transmural pressure would be very high. So this is why also patients breathing spontaneously are at risk of developing pulmonary edema on top of their lung injury, and I think we see that more often than we think. Without the transmural pressure, you lose this information. So I know it's complicated, but it's not because we like complications, it's because physiology is complicated, our patients are complicated, but I think it's a very exciting journey to try to understand that better. Thank you very much.